Hello, my name is Yejun Hong. I'm a medical student at the University of Calgary, and our team is here to discuss myotonic dystrophy as a link between ophthalmology and neurology. Eye, as a sensory organ, is very closely linked to the central nervous system. It is very close to the brain, and 4 of the 12 cranial nerves innervate the eye. 2 is for perceiving the light, and 2, 3, 4, and 6 are for movement or efferent functions of the eyes. The retina also has a neurosensory layer that becomes the optic nerve, cranial nerve 2. So sometimes there is discussion about where the eye ends and where the nervous system starts. Myotonic dystrophy is a lower motor neuron pathway disease, and while it is a disorder of the neural pathway, it can also affect the eye as part of its constellation of symptoms. Myotonic dystrophy is the most common form of muscular dystrophy and is also one of a group of diseases called chronic progressive external ophthalmoplegia. The onset of this disease is on adulthood. With muscular dystrophy, the characteristic features on the eyes are bilateral ptosis and lid lag. Lid lag is observed when the patient looks up and then down as the eye turns downward. Usually the upper eyelid follows downwards, but in lid lag, this corresponding movement slows down and lags behind the movement of the eyes. The orbicularis oculi is weakened as well. And Christmas tree or polychromic type of cataracts can also be observed. Pupils narrow and form a myotic pupil on observation, and there may be pigmentary retinopathy upon the fundus exam as well. When there were settlers first living in Quebec, there's a founder effect that increased the proportion of the population with myotonic dystrophy. Therefore, people in Quebec have a higher risk of myotonic dystrophy statistically, and hereditary factors play a role too in autosomal dominant fashion. The MPK gene, with its trinucleotide CTG repeat expansion, is known to contribute, and abnormal mRNA can interfere with other gene splicing. This genetic contribution to myotonic dystrophy is known to worsen over generations, which is known as anticipation effect. Type 1 myotonic dystrophy is with DMPK gene on chromosome 19 on the arm Q13 locus, and type 2 involves CNBP gene mutation on chromosome 3 on the arm Q21. The symptoms of myotonic dystrophy includes frontal balding and myotonia, as well as facial atrophy. As mentioned before, myotonic dystrophy is part of the CPEO, or chronic progressive external ophthalmoplegia, where the extraocular movement of the eyes become more and more restricted. Bilateral ptosis, or low-lying upper eyelids, and lid lag, as discussed before, can be observed, and orbicularis oculi weakness can also be present. These are signs of myotonic dystrophy. So this varies from cognitive impairment to cataracts in polychromic pattern in the lens to myotic pupils and pigmentary retinopathy, and the heart cardiomyopathy, and the lungs respiratory suppression, and hypersomnolence as well. Also look for temporalis muscle wasting along the temples of the head. And male patients can also present with testicular atrophy. If myotonic dystrophy presents in a fetus due to genetic reasons, polyhydramnios or excess amniotic fluids and reduced fetal movements may be observed. And after birth, hypotonia, diffuse weakness, respiratory failure, and tented mouth may be present. Later on, the child goes through cognitive and motor delay throughout their development, and cerebral atrophy affecting their coordination, and cardiorespiratory complications in their 30s and 40s may occur. Downgaze palsy due to lesion of RI-MLF is also possible, as well as upgaze palsy, which can present similarly. Progressive supranuclear palsy, which is a type of Parkinsonian syndromes, can be an alternative diagnosis. And dorsal midbrain syndrome, as well as myasthenia gravis, can coincidentally have a similar pattern in terms of the eyes. So in seeing such patients, take complete history, including past ocular and medical history, their status of wearing glasses or lens, any past ocular surgery or LASIK, any reason for hospitalizations in the past, as well as ophthalmic diseases in the family. Taking basic social history, such as any drugs, and their occupation would be important. Look to see if they are smoking or taking alcohol, drinking alcohol regularly. Check for allergies, as well as sexual history. Physical exams in terms of the eyes include checking for visual acuity, pupils, and pressure, looking at and performing cranial nerve exam, especially of the cranial nerve number 2, 3, 4, and 6. And this is done by checking extraocular movements for 3, 4, and 6. Doll's head maneuvers involve quickly turning the patient's head side to side or vertically up and down while holding the eyelids open, and checking if the oculocephalic reflex, where the eyes move opposite of the direction their head is moving, is present. Forced ductions or forced moving of the eyes after freezing them might be another physical exam that can be looked into when the CPEO has progressed to an extent. Investigations of myotonic dystrophy includes genetic testing. Look for DMPK expansion size or how much the sequence repeats. Normal is less than 35. Myotonic dystrophy is typically with the expansion size of over 50, and if it's congenital, over 4,000 copies may be observed. Muscle biopsy from the thigh or deltoid can be taken to look for abnormal ragged red muscle fibers. Or if no biopsy, or in addition to biopsy, electromyography can be checked for any conduction abnormalities in the muscle. Look into the ECG for any signs of cardiomyopathy, and rule out CNS process through lumbar puncture. Endocrine abnormalities, such as diabetes, thyroid, and hypogonadism, can be evaluated with their own set of lab tests. Keep in mind, this is just the entire list of most of what you would do in all the patients with myotonic dystrophy added together. You wouldn't necessarily do all of this all the time. Unfortunately, there is no effective treatment for myotonic dystrophy. Topical lubrication with artificial tears every hour and ointment before going to bed can be protective against exposure keratopathy. Surgery may be required if the uh, lids keep coming down to an extent that it affects the daily functions of the individual. Unfortunately, myotonic dystrophy has poor prognosis as it has multisystemic effects that are adverse for the patient. So here is, again, the link slide between ophthalmology and neurology, and hopefully this has been strengthened by our exploration of myotonic dystrophy. Here is a helpful flowchart as a summary of everything we've talked about in this presentation. And here's a list of references we've used to collect information about myotonic dystrophy and its ophthalmic complications. Thank you for watching this video.